Welcome back to Get Lit, the Dermatology Digest Literature Lessons podcast with Dr. Ted Rosen, a professor of dermatology at Baylor College of Medicine in Houston, Texas, and the editor-in-chief of the Dermatology Digest.
Hello, everyone. This is Dr. Ted Rosen, bringing you another edition of Let's Get Lit, brought to you by the Dermatology Digest, while we talk about some recent literature. Let's get started with acne. There was a systematic review in the May issue of JAMA Dermatology indicating that those home LED devices, both red and blue light, proved efficacious in reducing both inflammatory and non-inflammatory lesions. So that might be something you can do to augment your kind of standard therapy in some patients who are being recalcitrant as far as responding. We're still arguing about isotretinoin in the July issue of the Journal of the American Academy of Dermatology, looking at data gathered from the U.S. Food and Drug Administration Adverse Event Reporting System. Authors noted that there were lots of reports of psychiatric disorders, including depression, suicidal ideation, anxiety, altered mood, and self-injury and psychoses. The authors asserted that the risk of that is 3 times greater in those taking isotretinoin compared to matched acne patients. Yeah, maybe, maybe not. They still can't prove causality. And there's a self-reporting bias in these reports submitted to the FDA, uncertainty about the diagnosis. So I'm still a little skeptical. I think you need to be practical. If someone has a serious prior history of mental health disorders, I get clearance before I administer isotretinoin. What if you're having trouble controlling rosacea in a female? Always ask about hormonal intrauterine devices. In the February issue of the Journal of the American Academy of Dermatology, there's a whole story about hormonal compared to copper IUDs being associated with rosacea. So if you're having trouble controlling someone, think about that. Recent literature really shows upadacitinib's superiority in treating atopic dermatitis. In the February issue of Pediatric Allergy and Immunology, considering pediatric patients only, upadacitinib was found to be more efficacious than dupilumab, abrocitinib, and baricitinib. And in the December 2024 issue of British Journal of Dermatology, upadacitinib was found superior to dupilumab in moderate and severe atopic dermatitis in adolescents and adults. So on almost all the big meta-analysis, upadacitinib works quite well. That doesn't mean the other ones don't work, whether they're JAK inhibitors or biologic drugs, but it's a pretty reliable agent according to the most recent literature. I was somewhat surprised by the March issue of Photodermatology, Photoimmunology, and Photomedicine, a large prospective Swedish study, 40,000 patients. Turned out that those women who were on hormone replacement therapy over a 10-year study had an increased risk of basal cell carcinoma, squamous cell carcinoma, and yes, even melanoma. So if a female patient is having lots of recurrent cutaneous carcinoma, you might, if they're on hormone replacement therapy, consider at least discussing that with them and with the person supplying that hormone replacement therapy. Very excited about a really small study that was done in Australia. Patients who received immune checkpoint inhibitors, anti-PD-1 and PD-L1, for the treatment of cancer were also followed along to see what happened with their actinic keratoses. And the mean number of actinic keratoses dropped like a lead rock in water, really, really reduced. It was only an N of 23, but it suggests, based on this April JAMA Dermatology article, that perhaps someday in the not too distant future, for patients who are having lots of actinic keratoses, we might give them a short course of immune checkpoint inhibitors and eradicate their AKs, at least for a while. And talking about AKs, there was an article in the February issue, also of JAMA Dermatology. Two different cohorts, investigators did not find an increased risk of major cardiovascular events among those who were taking nicotinamide as anti-skin cancer prophylaxis. There had been some suggestion that might be the case, but I think this article pretty much shut the door on that one. There's been some recent literature on Merkel cell carcinoma, all of it actually pretty interesting. Survival rates for Merkel cell carcinoma have increased dramatically, and that is based upon the use of those same kind of drugs, PD-1 and PD-L1 immune checkpoint inhibitors, this time as treatment for the Merkel cell carcinoma. And it really has led to survival, even in metastatic disease, up to 54% survival rates, at least over a 2-year period. That was in the July issue of the Journal of the American Academy of Dermatology. And another article on Merkel cell carcinoma, March issue of Experimental Dermatology, looking at 9 studies consisting of 4,626 cases of primary Merkel cell carcinoma, disclosed that such patients are likely to develop a secondary skin cancer, most commonly basal cell carcinoma. So if you make that diagnosis of Merkel cell, you need to really watch them for other cutaneous carcinomas. Some interesting literature suggested we be on the watch for a highly selective PDE4 inhibitor called erismolast. And it looks like that may be very good for moderate to severe atopic dermatitis, based on an article in the May issue of British Journal of Dermatology. And there's also been some recent literature on that same drug, erismolast, that's coming for the treatment of psoriasis. An FDA announcement, a press release, indicated that they have approved mirdametinib. It's a highly selective MEK1 and MEK2 inhibitor for the treatment of inoperable symptomatic plexiform neurofibromas in adults and pediatric patients over the age of 2 with neurofibromatosis type 1, NF1, classic neurofibromatosis. These big plexiform lesions that can cause not only disfigurement, but discomfort and dysfunction respond with a fairly decent rate to this new drug, mirdametinib. I doubt we will be administering it because there are significant potential side effects, but you should be aware that this drug is approved and available for your patients with these big plexiform neurofibromas. There was an interesting Egyptian study of over 700 patients published in the March issue of Archives of Dermatology Research that showed that patients are less adherent to topical therapy in general than to systemic therapy. No one likes smearing stuff on. We're a pill popping society, so that wasn't too surprising. Also, if you give them multiple drugs and especially ointments, patients will be less adherent to those. As soon as they have one side effect, adherence drops dramatically. I doubt that this Egyptian study is any different from our patients here in the United States. I think there was a very important study done in France, published in the April edition of JAMA Dermatology. They looked at keeping pemphigus vulgaris in remission. And they said you reduce the likelihood of a relapse if you give a third dose of rituximab at 6 months after the standard 2 doses, 1,000 milligrams on day 1 and 14. Then you wait, theoretically, for a year. But this French study indicated that, in fact, if you gave a 6-month dose, you greatly reduced the risk of relapse. And of course, we're very happy we have something that generally works for pemphigus, but you really want to keep people in remission. Decades ago, pemphigus was a death sentence, and now it can be controlled. Keep that third dose in mind at 6 months. In the June issue of the Journal of the American Academy of Dermatology, there was an interesting analysis of the use of doxycycline in combination with other commonly used agents for the treatment of scarring alopecias, and they found no difference in the efficacy between using a low dose, 40 to 50 milligrams daily of doxycycline, compared to high dose, using 100 to 200 milligrams of doxycycline in the management of lichen planopilaris, frontal fibrosing alopecia, and central centrifugal cicatricial alopecia. So if you're going to use doxycycline as part of your multimodality regimen for these scarring alopecias, feel free to use a lower dose, which is significantly less likely than the higher dose to have gastrointestinal side effects and photosensitivity. The European Center for Disease Prevention and Control, that's like our CDC, except for Europe, has reported there have been 80,000 cases and 46 deaths due to chikungunya virus infection. So far, that's just the first half of 2025. Those cases have been largely from Brazil, Bolivia, Argentina, Peru, and Pakistan. Keep in mind, in the US, we have not one but 2 vaccines for chikungunya, recommended to be given to people who are going to be traveling to areas experiencing a current chikungunya virus outbreak. Repeating, Brazil, Bolivia, Argentina, Peru, and Pakistan. If you have patients traveling to those areas, I would recommend that they get one of the 2 chikungunya vaccines. The one that's an attenuated live vaccine, however, is no longer being given. It's been suspended to be given to older individuals, 60 years of age and older, because of potential side effects. In the June JAMA Dermatology, there was an article, it's a prospective Chinese study showing that 5-ALA PDT was successful, get this, even as monotherapy for culture or PCR verified Mycobacterium marinum infection. When combined with antibiotic treatment, the PDT decreased the required duration of antibiotics from about 4 months to half of that, only 2 months. So as many of you do have access to aminolevulinic acid photodynamic therapy, consider that if you come across a Mycobacterium marinum infection, administer the PDT to the infected site along with one of the antibiotics that's recommended for that kind of infection. When it comes to psoriasis, I think the trend has been, after successful use of biologic agents, try and increase the interval between doses. In the February issue of Experimental Dermatology, a retrospective Italian study showed that this could be successfully done, maintaining excellent efficacy for risankizumab and guselkumab. So once you obtain control, you may slowly increase intervals between dosing, decreasing total drug exposure. A very telling article in the July issue of Journal of the American Academy of Dermatology was a 4-year-long prospective Israeli cohort study comparing early initiation of hydroxychloroquine to topical-only therapy for what appeared to be cutaneous lupus erythematosus. But it turns out that administration of hydroxychloroquine in the standard dose, 200 milligrams twice a day, the topical-only group, they got topical corticosteroids and or topical calcineurin inhibitors, developed systemic disease, 27% of them, whereas those who received hydroxychloroquine at the initial start of therapy for their cutaneous lupus, only 4.8% of them developed systemic lupus. So I think the message here is that early initiation of hydroxychloroquine therapy may help prevent the development. It's a protective thing, prevent the development of systemic lupus. So use it early regardless of the morphology. If it just looks like discoid lesions, but those patients can develop systemic disease down the road, the use of hydroxychloroquine may be very important to prevent that from happening. So other than talking about a couple of drugs that we don't use and a drug that's coming, I think most of these pearls from the literature are very practical, and I hope you'll be able to use them in the coming days. Get ready. We'll have another edition of Let's Get Lit in a little while. This is Dr. Ted Rosen, editor-in-chief of the Dermatology Digest. Have a good day.
Thank you for listening to the Dermatology Digest's Get Lit podcast. For more information on any of the studies referenced, visit thedermatologydigest.com.